first question, we got a question actually from, for Pierre Bekens, and the question is coming from the European Society for Phenylketonuria, and they are trying to plead the government to give early diagnosed screening, neonatal screening to this population, and because it prevents the disease, and because they think actually that this kind of screening should be given to every child under 3. So, question is, okay, I understand what they are asking for, because obviously they are really on this matter and they really want to change things, but is it something that people can do and that we can afford for this disease, but also for other rare disease, for children, for women, pregnant women, maybe for other populations?
Well, screening for metabolic disorders is of course very important, and PKU is the most impacting example. I cannot give specific answers for Europe. I'm assuming it is done on routine even for undocumented immigrants, but I'm sure the problem is what's next if the result is positive, and how to coordinate the care. In the case of PKU, one issue must be, I've not seen studies, I'm sure they might exist, is the access to the appropriate diet.
Yes, that's what they said.
That you need if the baby is diagnosed positive, and I think this should be taken into account by migration authorities to grant permanent resident status, because I cannot imagine a child with PKU being moved from one country to another, maybe one camp to another, and being able to have the diet he or she would need. So they definitely have a point, and I think this is a concrete role for the national academies represented here, to support this and to make these kind of specific statements, because they could be seen as being very specialized, but they are not specialized. It's a young child with a disease which can be treated by appropriate nutrition, which would be very difficult to do by moving along.
Mm-hmm. And the other question is for Luciano Sasso, and it comes from a dentist actually, called Diego de Surai, and he's here in Belgium, and he's the founder of Dentists Without Borders. So after many years having people coming to his practice to get cares, he decided to create an NGO and to provide fundings and also everything they needed to cure people. And so Diego's question is, now for 4 years, because since he has created the NGO, after that he came back to his own practice, he said, for 4 years I have been receiving migrant patients free of charge in my office. Question is, what are universities doing to stimulate this social and moral role for future practitioners? Since he said, actually I'm doing it, other colleagues are doing it, but not everyone. And the thinking was, maybe if each dentist took 2 patients a year, it might be enough to cure all the migrants coming to Belgium.
Thank you. It's a very good question. And again, this website that I show collects good practices like this one. So I'm not aware, to be honest, in relationship to dentistry, if there is anything specific like this. But if not, we can make publicity about this initiative and be on the website, make aware, several hundred universities about these possibilities. Many of them, they do have a faculty of dentistry, and so maybe some other dentists can get this idea and try to use a little bit of their time to provide this care. So thank you. We can try to spread this is an excellent initiative. Thank you.
Mm-hmm. Anyone has a question? Because I still have a lot of questions to ask, so feel free to ask one. Yes? Rosa?
I have it, and I think that there's been a lot of talk since the morning on the need for more data and more research on a lot of areas. My question is, health data is very sensible too, and some of you have mentioned the issue of trust. And for vulnerable populations such as migrants, is this a problem, and how do you see that we can tackle this?
Right. So clearly, like other populations who are excluded, migrants have legitimate concerns. There's a long history of misuse of data. And I am confident that with the right systems and trust and engaging communities early, so the whole concept that is imagined in a lot of biomedical research of engaging the people that you are doing the research from the very moment you are conceiving the ideas and speaking to them about what would be useful and how would you get them to trust your ideas is the key to that. If you can engage people early, you can find out the things you need to do to achieve their confidence and to allow them to be able to participate. And that may include levels of anonymization that we don't currently do. It may include engagement by employing some of them within your research itself so that they're able to trust that what you're doing is something that they can replicate and protect themselves. Or it may entail that we'd have to accept in some instances we change what we are doing to reduce the risk that may be outside our control. Key to this is in instances where there's legislation in the state that mandates the sharing of information. You may purposely choose not to do that piece of research because you may end up causing more harm than good by doing such research. So I think it is possible to end positively, but it needs to be with full engagement of the communities we are trying to work with.
It's probably going in the same sense, the same direction, but I have a question. Let's pretend I was a migrant, which is not difficult with me because I'm the second generation. So let's pretend I was. How would I do if I left my country with a disease? I don't know, for example, diabetes, and I had to come to Europe and then go from one country to another. Would I have a file following me, like a medical file? Would I have the insurance that I can get my medicine, because I would definitely need it? So how could I do that? And is there a risk for a migrant to provide some kind of information and then being blocked or pushed out of a country?
Right. If I had the answer to that, I would probably have solved that issue. It's actually a real challenge that especially the migrants from Syria have seriously faced. The narrative that these are really poor people that do not have access to healthcare absolutely isn't true. Many people that left Syria made very middle-class existence, not very different from the lives that many ordinary people live in Europe. Now access to chronic disease management, including diabetes, hypertension, etc. And for many of them, during the course of this journey, they lost that, and people lost their lives and suffered quite a lot. There's a lot of innovation that has happened, some of it with EU funding, some by the big NGOs, Doctors of the World, MSF, etc., to try to tackle that with incredible innovation around electronic records that the patient holds themselves, as well as other systems to get around that barrier. But ultimately, I think the EU and nation states need to sit down and tackle this. If we are serious about solving it, we have to create a barrier, a solid wall that separates out the sharing of health information from immigration enforcement and the consequences. And until we do so, we will have to provide the healthcare at the margins through good initiatives such as the doctor, the dentist that you mentioned, and all the bigger charities and NGOs. But it's a real problem that migrants face as they move across different parts of the world.
Mm-hmm. Is there anyone who's a general practitioner here in the room? Yes? May I ask you a question, because I think it's interesting to share the information all together. Did you ever had someone coming to your practice and asking for care, though you had no papers, no documents? And what did you do? What do your colleagues or co-workers do in this kind of situation? Because we know that here in Belgium, some people are sometimes scared of doing something for migrants, since they don't know if they can be prosecuted after.
Well, I'm definitely not representative for all GPs, and I work in a countryside village practice in the Netherlands, which has a slightly different arrangements for undocumented migrants also. So I have seen, most of the people we see are the ones with a legal status, and I think the ones without a legal status have many of the barriers already mentioned, and they usually first go via other channels. I know research project in Sweden where we tried to look at barriers for NCD care, diabetes care, also for migrants, both documented and undocumented. And we saw there that apart from the legal barriers, which are there also in Sweden, a bit similar as here in Belgium, even if you would arrange to bypass that in some local research setting, then still trust was the major issue for migrants not to access routine healthcare services. So I think that's where the NGOs still have a special role to play, even if you would have in theory the good access setting up. But one of the things you can do is, of course, sensitize healthcare workers in the routine healthcare services on this issue, because I think many healthcare professionals are not so much aware of this trust issue, and then organize the sensitization and ways to train them how they can from their perspective change their attitudes, be more aware and be more open towards providing access to these people.
Thank you. I think there is a question just behind you.
What I would like to add to that is if you are not acquainted with the country, it's often very difficult to find GPs, and people go to the hospital. Yeah. And that's also often from the countries where they come from. In their mind, you seek healthcare, you go to the hospital. And I think that is an enormous burden on emergency departments in the hospital, and that should be very deliberately tackled, because people would be much better served in primary care, but it's very difficult to find primary care. Hospitals usually in administration know how to deal then with these people, they have contacts with the social services, but for the GPs also it's much more difficult to find their way, and for the refugees or the asylum seekers it's also much more difficult to find their way to general practice.
You can pass the microphone over there. Thank you.
Hello. I'm working in hospitals, so we are in a chain. Well, I would like to reply on the issue of trust and fear, both from the patient side and from the doctor side. From my experience, whenever undocumented migrants arrive in the hospital, then they have already overcome some kind of fear and so on. So let's assume, let's not talk about that, but about fear of doctors. In my perspective, it's not so much fear for doing something illegal. I think that we are relatively relaxed about that in Belgium, but it's more the tension field between, as a medical, you know what you need to do and what you want to do, and you want to go on with the medical case and do what you should always do. And then there is, of course, first of all, administrative hurdles, because somebody who has no papers for anything you need to do for prescriptions.
Yeah, a blood test, for example.
Well, even before you can think of a blood test, you need to enter your patient in the system, and he has no papers and so on. So that's already complicated. So usually we manage to do that somehow, but before that you cannot proceed. And then, indeed, who is going to pay the bill? As you said, usually hospitals are somehow relaxed. My hospital is relatively relaxed. Maybe I should not say that too loud, but I mean, it depends also on where you are located, what is the burden, what is but social services do have a lot of administrative work with that. They know very well all these systems and all the rules, but it's a lot of administrative burden. But again, from a medical point of view, if something serious is going on and you want to proceed medically, you need also to do also the bureaucratic stuff. So that is much more plain than the fear of being persecuted for doing something illegal. And so we want to do the proper medical thing, but without all this bureaucratic stuff.
Thank you so much for sharing your experience. Mr. Spira?
Yes, I want to try to answer your question. I believe I was with diabetes and going from one country to the other. The question was part of a discussion we had in France just last week with a vote by the French Parliament of new regulations concerning access to health for migrants. In France, we have, like in almost all countries, I think, a green card, word chip in it, with medical information, mainly health insurance, social security information in the card. There is a project in France for the last 15 years, since 2004, to include in this card medical file, personal medical file. This is called dossier médical partagé, share medical file. It doesn't work. One of the main reasons, if not the main reason why it doesn't work, is for the problem of protection of individual data. If you put your data, your health data, on your credit card, because it's exactly like a credit card, it's a credit card because you have access with this to all medical services. If you put your personal data, you are not sure that Mr. Google is not going to be able to read your data. So it doesn't work until now. They try very hardly, but it doesn't work. The proposal from the French Minister for Health last week was to oblige migrant people to have such a card, including their medical data.
In France?
In France,
You cannot
yes.
force anyone to
So
do
it's
anything.
really interesting because regular French people are very reluctant to have their medical data on this card. But this could become mandatory for migrants.
Yeah.
I will go further in my presentation.
Yeah, okay. Thank you. Yes?
May I have two? Thank you. I'd like to give two examples that show how much policies influence all these aspects of migrant health. For example, we got the information from people who give care to refugees in countries as Italy or Slovenia, Croatia, and who wanted, where the attempt was made to establish a personal health record for these people so that they can get their records with them. That there are quite a number of refugees who don't really appreciate this idea because they don't want to have documents where it is stated which was the first country they have entered because of the Dublin regulation. So this is also a kind of trust issue, or distrust issue. And the other issue is that what we know from NGOs and people working in the field of health, in the field of regular health care, is that the situation often gets worse as soon as people get the asylum status granted. Because then it's no longer NGOs who are caring and who are trying to provide interpreting services and who are giving information and social support. But now they have to address the regular healthcare system that is not prepared to react to all these issues. So,
yeah,
just
thank you.
examples.
Thank you. Do you have anything to add? No?
I could just make
Yes.
one comment. Yes, thank you. I could just make one comment about the UK. We have an interesting system called the Public Health Act, and that means that any communicable disease which anyone in the country has, be it a UK citizen or a migrant, will get free healthcare for that disease. Now, this is public health and so on. So in my own unit, for example, in an area of deprivation in London, we exercise that quite frequently with tuberculosis, with people who have bad respiratory tract infections. They will get free care, irrespective of the country they come from. And the idea is you are protecting the public, of course. That's it.
Okay, thank you. Thank you so much. Yes.
Maybe just to echo what has been said, I think it's very important not to assume that the access to healthcare in the country of origin is worse than here. Well, here, I don't know, but worse than in the US, that would be hard to beat. And it's really a problem for Mexican immigrants, because Mexico has a very good health system. Yesterday with Freddie, we were talking about contraception, for example. You know, many of my Mexican friends assume that it's normal to have an extraordinary, publicly funded family planning system, and then they move to the US, they become a legal immigrant, and they are surprised that they cannot find their contraception anymore, because they never thought that it could be possible for a country not to have that. So clearly in the case of Mexican immigrants, it's quite a shock for many. It's a problem for immunization. There are very good studies in El Paso, Ciudad Juarez, which is one city divided
You
by...
can hear the good accent. Huh? Sounds great, the accent. That's your wife.
it's you can see the other side, and for many indicators, maternal and child health, which is my field, the coverage is better on the Mexican side. So how to deal with that, and it's important certainly for the Syrian refugees and in general.
Okay, thank you. Let's have a break. A coffee break. Oh no, sorry, not yet.
I just add another complexity. In Geneva, what we're seeing is that among Latin American migrants, irrespective of whether they can have access to the hospital or to other services, have developed a parallel system. So we have Latin American doctors who are not registered. In some cases, we have traditional doctors working. And we have parallel pharmacy systems in which they fly over traditional medicines, for example, from Peru or Bolivia to Geneva. So I think this is another additional complexity, because this is, as I say, parallel. It doesn't fall under any legislative agreement. It's not authorized, it's not evaluated, but it's a growing phenomenon.
I would argue that that's probably not unique to those migrants. Anecdotally, registrars that come to work in my department from across Europe, instead of waiting on the queues for the NHS, they pop back to Spain or elsewhere and get their treatment quicker. Human beings would always do that. You efficiently seek access if the system isn't responding to your needs. And the need and the solution goes back to the state and the relevant other organizations that support care, providing something that meets the needs of those migrant communities. And unless that's done, humans will find solutions elsewhere.
Well, Ibrahim, just to add to that, I mean, one of the things that we have seen talking to people, it is not necessarily that they cannot get access. They simply feel that the traditional system that they're using is superior to the local.
Read this month's Journal of Internal Medicine. You will see a debunking of traditional Chinese medicine by Fi and Zhang, which has caused a great stir in China. I live in London with a high South Korean population where I live. We have 2 traditional Chinese medicine shops, and people flock in the weekends to get remedies for coughs and headache and so on. And you're absolutely right. Except for me.
Shall we have a break? Yes? Let's go, 15 minutes.
Coffee,